that was the first part. There was obviously a huge documentation. We drew a lot on UNAIDS reports, which covered this ground, and a lot of that is us putting that into context for the purpose of the analysis that comes later on. The second part of what we were asked to do was to say, well, which of the activities, which of the policy interventions, which of the events have actually led to that improvement in access? So we spent a long time in the report, for people who will work their way through it, talking about some of the history as to what's happened across a whole set of countries before going to the case studies as to what's happened since 2000. And a lot has happened. Lots of people in this room have contributed to a lot of these things happen. But we've got a real change in terms of political will. We've got countries actually accepting the extent of the problem, initiating universal access programs, being willing to participate in partnerships. Going back into 2000, that wasn't the case in all the markets, although it was the case in some. We've seen significant progress in the domestic health systems. What do we mean by that? Well, we mean funding to some degree, so domestic funding for HIV medicines, but also the infrastructure that's needed for medicines to be useful. Diagnosing, testing, actually keeping patients on the medicines by providing a support network afterwards. That's not about just access to medicines, it's also about creating an environment where patients are willing to come to the health system and overcome the problems of stigma, which when we go back to 2000 were much more significant perhaps than in some of these markets are today. So that was also an important part of the domestic healthcare system. International funding is obviously the thing that is often talked about in this, but it needs to be put into context. There has been a huge increase in international funding, the development of the Global Fund, the advances of PEPFAR, etc. This is clearly a very large extent of activity, largely focused on the lowest income countries. The innovative industry has changed. The innovative industry is doing different things now than it was doing at the beginning of the decade. There is much more universal use of differential pricing. Voluntary licensing arrangements are much more common than they were. The involvement of the industry in partnership has developed through the decade. The generic industry, the Indian generic industry and the generic suppliers in different emerging market countries has obviously developed out of all recognition since the year 2000, and therefore a huge role potentially has been played by the arrival of competition in the different antiretrovirals and the lower price that comes with generic competition. And then clearly some countries have used compulsory licensing, and one country has used paragraph 6. So a large part of the report is setting out the range of factors, again, drawing on the literature, drawing on a lot of what people in this room know, but setting it out in context and setting out the existing evidence, and some very good existing evidence, some of my discussants today, in terms of what we already know about the role of those factors. To try to understand how each of those factors plays out, we've done two things, as I was describing earlier. The first thing is to look across our 7 case studies. So we cover a different range of countries. Even though we've chosen 7 countries, these are 7 countries with very different starting positions in terms of the HIV epidemic. We have concentrated epidemics and generalized epidemics. We had countries from the different regions of the world. We also clearly had countries from different levels of income. We only have one low-income country, but we have upper and lower middle-income countries. What's clear, as I was saying earlier, is that we've seen significant progress in coverage rates by the 2006 or the 2010 definition in terms of access. These are successes, relative successes. All countries could do better, but all these countries have achieved significant progress over the period, or started with a very high level from the beginning. So the first analytical part of the report tries to look at what we can see in terms of changes in coverage rates. So we've got Rwanda here, and in the top left corner is, I suppose, what we're trying to understand. How have we seen the significant increase in coverage that we've seen starting back at the beginning of the decade as we work through to the end of the decade? And then we've looked at many measures of the different policy interventions, and we put some up here in terms of domestic spending, some up here in terms of the intervention on prices of some of the best-known molecules. And what we're trying to connect is the change in policy instruments to these measures of success. So in the case of Rwanda, there clearly was a change in political will or political focus at the beginning of the decade. This led to a political commitment and partnership with the Clinton Foundation starting in 2002. We had progress going through from joint procurement to using its own procurement, and clearly procurement and negotiation is a significant part of this story. We then, in Rwanda's case, did have the use of paragraph 6, the one example we have of the use of paragraph 6. So for all of the case studies, and we can talk about some of them in more detail as we get into questions, we've done the same process of trying to understand progress, trying to understand some of the measures that inform us about the extent of some of the interventions, and then trying to understand the timing. When did these policy interventions actually happen? And is there any relationship to when they happen to the increase in coverage that we see? And this led to us, as you'll see, we spent some time going through the 7 different case studies, and then we've tried to draw some conclusions from what you get across the different markets. And we've spent many a fun hour, as you can imagine, trying to evaluate the most important factors in improving access. So what does this table mean? Well, this table doesn't mean, for a start, 1 star means you're doing badly. That's not the point of the table. What this table says, in seeing the relative improvement in access we've seen over the last 10 years, and in all of the case studies we've seen an improvement, what do we think, from the academic evidence we've seen, the interviews we've seen, and the assessment of the quantitative measures we can gather, have been the most significant elements that have contributed to that improvement in access? So this is not meant to say if you have a 1 star that is a bad thing. This is meant to say all these countries have been successful relatively, which of the factors from the qualitative perspective come out as being most important. So in the case of Rwanda, which I went through earlier on, clearly political will was an important part of the story starting from 2000. There's academic evidence showing the importance of dealing with stigma in terms of getting people into access to the healthcare system. International funding has been a huge part of the Rwanda story, 94% in terms of the funding of HIV medicines. Procurement, the ability to use generic medicines, has been part of the story, and they've moved that from international shared procurement to domestic procurement, actually localizing some of the skills. But generic manufacturing has clearly been important. Compulsory licensing, or the use of paragraph 6, well, it was used once. It was used very late, while we'd already seen quite a significant improvement in access. So our assessment, based off the qualitative discussion for Rwanda, yes, it may have had an influence, but it wasn't a very significant one in the improvement we've seen since 2010. Bringing many of these factors together, partnership clearly was, both in terms of learning the skills and bringing those together, and in terms of actually the activity of actually getting efficient procurement, etc. And we do the same thing for the other countries, and we can, I'm sure, have a discussion as to whether you agree with our star-based system, or whether it's 3 or whether it's 2. But this is our assessment based off the evidence we could find and the interviews we had. So what are our conclusions coming from the case studies? Do I need to go a little bit faster? Okay, the conclusions coming from the case studies are, well, the date of when the Universal Access Programme was started is really important. You can see a very clear relationship between people who started the programme early and high levels of coverage. That doesn't mean countries that started later cannot reach the same levels of coverage, but it takes time to catch up. Why does it take time to catch up? Well, even if you have funding, even if you have low-priced medicines, either provided by the innovative company or by generic manufacturers, that isn't enough. You need a domestic healthcare infrastructure that actually delivers those medicines. You need a program of education and working with patients and healthcare workers such that they're willing to come in and get treatment. That cannot happen quickly.